Welcome to the Aesthetic Angle, presented by Monarch Plastic Surgery. Kansas City's #1 resource for all things plastic surgery, skincare, injectables, and wellness. I'm Dr. Keith Hodge, and I'm joined by my co-host, Dr. Joe Spaniol. Today's topic is breast implants. We're going to take a deep dive in the history of breast implants, as well as current topics and techniques. Take it away, Joe.
Thank you. So I'll provide a bit of a historical perspective. I think it's helpful just to know where breast implants started and compare it to where we are now. Implants were initially created in the 1960s. The first and second generation silicone implants were 60s to early 80s. They were a thin silicone shell and a low viscosity gel. That means the silicone was very oily. It would, if you were to, you could pour it out of a glass, sort of a thing. And then we moved on to third generation implants in the early 80s. The gel became more cohesive, meaning it has more cross links to itself. It's more cohesive. So that means it sticks to itself within the shell, the silicone shell, and it also sticks to itself better outside of the shell if you have a leak or a tear in the implant shell or a rupture. They also had multi-layered shells during the 80s. And then there were fourth generation silicone implants were the late 80s, which they added some texturing to, which comes up sometimes when we're talking about breast implants. Fifth generation was early to mid 90s, which were same as the third generation, but they sometimes had some anatomic shape to them, which were shaped like a natural breast. And they also increased the cohesivity of the gel with that generation as well. So even more sticky gel, like stuck to itself better, stayed within the shell, within the pocket. And now we're on to sixth generation implants, which have an even more cohesivity, more cross-linking, firmer gel, and more biocompatible layers as far as the shell goes. And so that's kind of where we're at now. And so it's been a long evolution, but where implants have been historically can still affect conversations we have with patients now. Absolutely.
I've always thought about that first conversation. The first implant was placed in Houston, Texas. It's the early 60s. Like, I have this idea. I want to put this foreign object behind your breast and make it better. That'd be an awkward conversation to have for the first time.
Yeah. I would have loved to have been a fly on the wall for that one.
Yeah, that'd be cool.
Yeah.
So you talked a lot about gel and viscosity and texture. So today, where are we, Joe? Are we saline or silicone?
I'm heavily in the silicone camp. I think silicone is softer than saline. It's lighter. It's a more natural feel. The implant warranties for silicone are better as well. Lots of reasons. Most patients in our practice go with silicone. Has that been your experience as well?
Yeah, I don't offer saline. If someone comes to me, I do a lot of redo breast surgery. Yeah. Over half my breast implant practice is redo, revisional surgery. So ladies come in with older implants. If they have a nice result with saline and they want to just, keep what they have, I will certainly do that for them, and the patient's in charge. But if I'm doing a primary augmentation, I'm going to talk about silicone. And the reason is the saline shell scallops the way it's produced. And so you never have full muscle coverage. So usually behind the muscle, the lateral breast is not usually covered by muscle. And so, especially in a thin woman, you can see the scalloping, especially in certain positions.
Or rippling is another word
for that. Yeah. But the actual edge of the shell is scalloped, especially if it's overfilled.
Sure. And when you started practice, that was during the moratorium on silicone implants. So you were only doing saline for the first few years, right?
Yes. I started in 2003. The moratorium was lifted in 2006 for cosmetic surgery.
Yeah.
Interesting enough, during that time, if you had breast cancer and needed reconstruction, you could use a silicone implant. But if you were a cosmetic patient, you had to use saline, unless you're in a study. So my consults were shorter then because all I had to offer was a saline implant.
Oh, sure.
So here's your saline implant. We just got to pick the size.
Sure.
And now there's many more options and many more choices, which is great for women's health.
Yeah.
And great just for patient satisfaction.
And I think some of the hesitation and the widespread, thoughts about silicone still sort of linger today when you converse with patients, right?
Right.
So how do you approach that when someone comes in and they're a little hesitant about silicone breast implants?
I will not give them all the details you just gave us.
Yeah.
But I will tell them that technology has improved.
Yes.
Our gel is much more viscous, which means it's not going to leave the breast implant pocket should you have a rupture. I'll tell them that the shells are much more thick and there's a better technology. So with today's 6th generation implant, if you have a rupture, it is a shell rupture,
Yes.
the gel is going to stay in the pocket. It's
Right.
going to stay within the shell.
Yeah.
I don't know if you've had this experience. I've actually cut the implant in half,
Yeah.
squeeze the gel, it leaves the shell. As soon as you let go, it comes back into
Yeah.
the shell.
Yeah.
The gel's not going anywhere.
Yeah. There's great videos we have on Instagram and YouTube and stuff, and it's easy to find that. Yeah. I tell patients it's like cutting Jello, like you get two halves.
Yeah.
Which helps. And then I think some of it is the verbiage. Rupture makes people think of an explosion,
Yeah.
and leak makes it think of like an oil leak in your car. It's like leaking onto the different parts of the car. And it's like I think the terminology there is a little flawed, because these are really just a tear in the shell. And it's not like it's going out all over. So some of that I think causes some worry when patients present. Anyway, so these are just some things that are worth discussing and covering when you consult. Anyway, but we can move on from that.
One more point about the shell. My favorite new implant is the Motiva implant.
Mm-hmm.
And I had the opportunity to visit their facility last week, and I got a tour of the implant where the implants are made. It is immaculately clean, and it is over a 20-step process, and it is a true monoblock. There's only one company that makes the gel for all the implant companies. And when they started their company in 1999, they said this gel is not adequate. It's not cohesive enough. It doesn't attach to the shell well enough. And so they have their own proprietary patented gel formula that only they have. And so all implants are not equal. Their gel is different, and it really integrates into the shell. So it's considered a true monoblock. So the shell to gel integration is fantastic. Mm-hmm. And it's another reason to feel like that is a safe implant.
Sure.
Because the gel's not going anywhere.
Okay. So speaking of the shell, one thing that makes Motiva unique, it has the micro texturing, right? And so what does that do? Why might someone choose that?
That's a very good question. And I talk about that in my consults.
Mm-hmm.
So we need to back up a little bit.
Yeah.
So there are smooth and textured shells.
Mm-hmm.
A smooth shell should really have no texture to it. Now, if you ask the scientists, there's no such thing as a perfectly smooth. There are some defects even in a smooth, microscopic irregularities, even in a smooth shell. Mm-hmm. But in a textured shell, we had up to 80 to 90 microns. A micron is 1,000th of a millimeter. So the older textured shells were 80 to 90 microns. This caused a large inflammatory response. So you had more scar tissue form. Mm-hmm. Well, the reason you wanted that, because if you had a shaped implant, an anatomic implant, so it's thinner up top, heavier on the bottom to give that nice natural slope, you not want the implant to move in the pocket.
Sure.
So you wanted that adherence. You wanted that inflammatory response and that scar tissue to hold the implant in place. Well, unfortunately, that's occasionally associated with ALCL or squamous cell carcinoma, and it is due to the implant, not true breast cancer in the sense of the way most people think about it. Mm-hmm. So there's been voluntary recalls on texturing, so we just really don't use texturing. Mm-hmm. However, Motiva...
And that was in the mid-2010s, right?
Yeah, exactly. So Motiva did research on the shell and found that a 4-micron microtexture is ideal because it causes a low inflammation response. They looked at how do the fibroblasts react to the shell. Happy fibroblasts are nice and flat and open. Unhappy fibroblasts are coiled and more circular under the microscope. And they found that with the 4-micron texturing, we got nice, flat, happy fibroblasts, which means a low inflammatory response, which means a very low risk of capsular contracture. And in their post-surveillance marketing data, at 15 years, less than 1% capsular contracture, which is the best ever published.
So compared to a smooth implant surface, which would be a capsular contracture rate of what for comparison?
It depends on the implant.
Right.
I mean, but at 10 years, maybe 5%.
Yeah.
Some would say 10%.
Yeah. So it's a real difference.
Yeah.
Yeah. And so the body likes a little bit of texturing.
Yes.
A completely smooth surface, the body doesn't know how to react. Is the idea, right? So the body tries to sort of wall this off.
Correct.
And that's why you get this inflammation on the smooth surface.
Yeah.
The fibroblasts get more condensed. They lay down more collagen, et cetera, and cause more of a capsule, which can be helpful.
Can be helpful, yes.
But also more of potential disease in capsular contracture.
Yeah.
So you feel like a little bit of texturing is sort of that sweet spot
between texture, like you described it.
Between the heavily textured, which increases risk of ALCL and other implant-related cancers, but not smooth. So something in between.
Yes.
But very close to smooth.
Yes.
0 compared to 80, and we're at 4 microns. What do patients feel? Because we still put in smooth implants.
Yeah.
They're still a great implant. We still use a
absolutely.
lot of Sientra, and I use some Allergan for reconstruction. What do you feel when you feel the two different textured or the two different implant surfaces?
Even though it's 4/1000ths of a millimeter, there is a tactile difference. You can't run your finger across it as easily. There's a little catch to it, as opposed to a smooth.
Yeah. We let patients feel them when they consult, and I feel like the Motiva is almost like a cell phone case that has just a little bit of tiny bit of grip. It's not completely smooth. Where smooth is smooth. So it's helpful when patients can look at it. Okay, so we talked a little bit about gel. So when patients present and they want to proceed with a natural augmentation.
Yeah.
So how do you take that? What does that mean to you as their surgeon?
Yeah. Natural
can mean a lot of things.
Natural is very personalized.
Right. Yes.
When I think of natural, I think of a natural slope to the breast, not a round upper pole, but a more gentle slope. That's what I think of as natural. And having done, over 1,000 consults, that is not always what the patient means by natural. So I will start showing them with our app probably a moderate profile implant. So you get the best of both worlds. You get some upper breast fullness, and you get some projection. And sometimes I nailed it, and sometimes I want more upper breast fullness. So to me, that's not as natural. But we're here to, provide a service and give the patient what they want. And I don't mind putting a high profile implant in, but to me, it's just not natural. What are your thoughts?
I kind of laugh sometimes to myself often when patients say natural and then they do the sizing and they pick a high profile implant. Because upper pole fullness to me does not mean as natural either. But I don't get hung up on what that means. I get more interested in sort of what their goals are.
The other thing patients say, I don't know about you know. I'm like, but you want to be bigger, right? And then you start sizing. And I start off really conservatively when they're like, I just really don't know about you know. I mean, like 250 or less. Oh, I want more than that. I want more than that. And before you know it, you're at 350 or 400 I'm like, well, people are going to know. You had an augmentation, which is fine with me.
Well, and along those lines, I think a lot of patients get caught up in a number too. Like, oh my gosh, 400 sounds way too big. But and part about sizing, I think it matters of the width of the breast that you're dealing with.
Absolutely.
And I'd love to have a tray of implants to show today, but I don't have them. But anyway, if you have a width of say 12 centimeters and you're getting X amount of volume, well, the low profile would be, a lower amount if you want. And as you go up, you need more volume to get more projection. So patients will say, well, gosh, 400 sounds really big. But if depending on the width of that side of their chest, if they don't want to go above 350, that might be a low or a moderate profile implant. So it sometimes takes some education to realize that, we're trying to match what you bring to the table. And sometimes it's what they see on TikTok, what their friend had or whatever. And it's pretty simple. And I try to tell patients too that, we have to start with what matches you. It has to fit you, know?
It's customized.
Exactly. Yeah. And so, our nurses are great at that here. So thankfully, and take some education, but it's fun. It's really fun. So, and I agree with you on saline. I think the couple times a year I do saline is usually when patients already have saline and they're like, I'm happy, if it ain't, don't fix it kind of thing. I have very few primary augmentations that go with saline, though I do mention it, but pretty much exclusively silicone for all the reasons we discussed. Let's talk a little bit about incision placement. So there's a few options for incision placement. What are all the options as far as how you could put a breast implant in?
Let's go from most common to least common.
Sure.
Most common is the inframammary fold approach, which means the base of your breast at the crease below the nipple really complex. There's the periareolar approach, which means around the edge of the flat part of the nipple called the areola. There's the transaxillary approach, which means you're approaching from the armpit and making a pocket and from top to bottom. So my favorite is the crease approach, the inframammary fold approach, because I feel like I get direct visualization of the structures I'm trying to manipulate to get the best symmetry, and it's just easier. If you're working from the periareolar approach, you really you're almost committed to a saline implant because you need to deflate the implant, roll up, and place it through a very small incision. And again, we're not doing saline ever. So the transaxillary approach, dissection is either done bluntly, which I do not like, or it's done with a scope, so you can see what you're doing. So to me, it just makes an easy procedure a little more technically demanding. I'm just worried about symmetry. So my approach is pretty much 100% the infrared fold approach.
Another fun one to talk about would be tuba. Transumbilical. Have you ever seen any of those? I've never have.
I've seen a couple of patients that have had it done elsewhere. I've never actually done it myself.
But like transaxillary, it has to be saline because you're traveling so far. And I also only do inframammary fold approach too. The studies are pretty consistent that capsular contracture is higher with periareolar or transaxillary for reasons due to bacterial load in the armpit and in the ducts that run to the nipple. So you and I both put clear dressings on the nipples when we do breast augmentation to minimize that contamination. So just another reason to go inframammary fold.
I worry about sensation in periareolar approach too. Being a nerve branch or something.
And I don't know that patients ever really get hung up on a small scar in their breast fold,
Not most patients, because usually, like you said, it's either in the fold, or even if you have more pigment in your skin, it's still in the fold. So you have to look for it.
I agree.
Let's talk about placement. What plane are we going to use, Joe?
Sure.
Are we behind the muscle? Are we in front of the muscle? Are we dual plane? Are we submuscular? Would you like to define some of those planes?
Sure. So submuscular would be completely under the pectoralis muscle. And then dual plane would be partially under the pectoralis muscle and partially under just breast tissue. So those are the two planes there. And then as we're moving deep to more superficial, the next layer would be subfascial, which would be within the envelope of the pectoralis muscle. If I explain it to patients, when you go buy a chicken breast at the store, there's that sheen around the muscle of the chicken breast. That sheen is the fascia, and that's the envelope that we would put the implant in for subfascial. And then the next layer up would be subglandular, would be completely on top of the muscle and the fascia. And there's also an intramuscular position, which I saw mentioned during a conference. I think they do that in other countries, but I've never seen it, never done it. It would be within the pectoralis muscle. Anyway, so those are the main placements as far as where to put the implant. What's your preference for placement?
Well, it has changed over the last year. I was always taught to be subpectoral. Now that means that you don't have coverage, laterally like you talked about. And that really is a dual plane because you're typically releasing the inferior fibers of the pectoralis major muscle to get that lower breast fullness and projection.
Yes.
And so when people ask me, I want the dual plane, I'm like, well, we've always done that. There are different degrees, dual plane 1, 2, and 3. If you're trying to get some more nipple elevation with your procedure, try to avoid a lift. But since Motiva became available in October of 2024, now we have a 100% filled implant. So I have changed from behind the muscle to probably 80-90% in front of the muscle because I was concerned before about implant visibility or wrinkling because every implant wrinkled prior to Motiva. But now I don't worry about that. And I've got, a good bit of experience now with Motiva implants from the muscle. I've not had any visibility, I've not had any wrinkling, so I'm very happy. And that avoids any potential for animation, which means if you're behind the muscle and you flex your pectoralis muscle, you can move your implants and misshapen the breast. And so we avoid that completely. And we also decrease our risk of lateralization, which means over time, as you flex your pec, you push your implants toward the armpit. So that pocket can get bigger over time. They still look great when you're standing, but when you're lying down, the implants will shift to your armpit and not look as good. And so, not that it can't happen from the muscle, because sometimes just the weight of the implant can cause some lateralization, but it's much less likely to occur. And I tell my patients, look, when I was, trained 27 years ago, we were taught go behind the muscle for more natural slope.
Yeah.
And better imaging with the mammogram or ultrasound,
Right.
and decreased risk of capsular contracture. So, it's controversial whether that is true or not regarding capsular contracture being higher risk in front versus behind. There's some good Canadian studies that show there is no difference because they put, I think, all of theirs in front of the muscle. So I think with 3D mammography, high resolution ultrasound, and a fully filled implant, I'm almost completely in front of the muscle now.
Got it. Yeah, I've had a similar evolution in my much briefer career. I was trained on dual plane, and dual plane 1, 2, and 3. And then my first 3 years in practice, that's all I did. And then I watched some conferences, read some articles, and when I came up here, most of the surgeons here were doing on top of the muscle, either subfascial or subglandular. And it was a kind of multifactorial, but a lot of the leaders in our field are starting to talk about revisions being due to the dual plane technique one way or another. Like you had mentioned, that pec muscle distorting or pushing the implant, it can be uncomfortable. I do think once I made the switch too, I get better control over medial cleavage as well, because you can control that dissection very nicely and you're not limited as much by the pec muscle. And then the couple other things that are helpful, I think patients get to their final result sooner.
Absolutely.
You're not waiting for that pec to stretch and things to settle.
Relax.
Their 6-week photos when you're on top of the muscle look like 3-month or 6-month photos compared to the under the muscle techniques, which can definitely help. If that patient is happy at 6 weeks instead of 3 months with how things look, that's only a good thing.
And they're so much more comfortable.
Right. That was the last point. Yeah.
A lot of patients take no pain medication
Right.
after surgery. They just ice and Tylenol.
Yes.
And say, I'm good to go.
Yep. We're kind of reining them in a little bit more than we used to, especially with, good multimodal pain medications and a nerve block too. Patients pain typically 2 to 3 out of 10 on the pain scale. Like I had a patient, she got home from surgery around noon and she got on the Motiva website and registered her implants faster than our staff could.
Yeah, no, it happens to me all the time.
Because good anesthesia and good pain control, she was just ready to get on with life. So it was funny. But no, all good points. It's been an interesting evolution. That's something I love about our field, is that we're always learning from each other and from leaders and researchers. And when you've got medical devices involved, there's always a push for competition and science and doing things better and better. And I love that. I love that, Motiva was a bit of a disruptor to the market, and for a lot of good reasons. It's exciting.
Yeah, so definitely innovating.
Yeah.
And one more point on the, from the muscle versus behind. I just had a patient Friday who had a plane change. So took her implants from behind the muscle, placed implants in front of the muscle. And I saw her 3 days later. She's like, I already feel better. Just having my pec back in its natural spot.
Oh, yeah.
She said, I feel better already. I'm having no pain. I'm not requiring any pain medication. So it's a nice option for most women.
100%. And from when I started practice, I was already doing reconstruction on top of the muscle. And then I was doing revisions on patients who'd had recon elsewhere that had all the things. They had animation and discomfort and, unnatural reconstruction. And then I would moving them on top of the muscle. And then it just became one of many reasons why am I not just doing that for augmentations too. So, all good points. The one thing patients may be concerned about when you're talking about up on top of the muscle would be seeing an edge, right? That's used to be what we would say, seeing an edge, seeing that unnatural slope. Has that been your experience?
Not at all. And I've placed some Sientras in front of the muscle and not had any issues, but certainly with Motiva on even thinner women, traditionally we were taught a 2 centimeter skin pinch, otherwise you're in trouble, meaning that how much thickness do we have here above the muscle, between your skin and the muscle? It should be a 2 centimeter skin pinch. I'm down to 0.5 centimeters and I've yet to see an implant ridge, ripple, wrinkle, or see the edge. Now the Motiva shell is different. It's hard to explain, but it's not just like a flat surface and then you have it has an edge on the bottom and a slope on the top and the bottom, I should say. And so it's not just an abrupt.
It's not a hemisphere.
Right,
Yeah.
right.
Which helps for sure.
Yes. The other thing I would say is the Demi Profile Motiva still gives a lot of upper wrist fullness and a lot of projection. So I've had all my Demi patients are very happy because they still look full. I mean, it's not like it doesn't do something. I mean, it still is a very good option for a lot of women who have some natural breast tissue and don't want to look extremely round. They still get good upper pole fullness and projection.
And what's the Demi for those that, don't?
It would be the moderate
Okay.
version of the Motiva line. Motiva has a mini, Demi, and full. It's I call it their low, medium, and high
Projection wise. Yeah. Okay. And then they also have round and ergonomics.
Right.
Is that within each of the three? I have to look at the catalog.
Yes.
Okay.
Yes. So round is a firmer gel, and it is designed to stay round in a standing position to keep that upper breast fullness. Where ergonomics is round lying down, but we stand up. There's a little bit of a slope to the implant.
Yes. Thank you.
Yeah.
How do you explain, let's see here, because implants are not lifetime devices, right?
Right.
So how do you explain that to patients, and what is something that they should be thinking about once they're healed and happy after an augmentation or lift with implant?
And I'm surprised at how many women don't know that because we really stress that.
Yeah.
But I think back in the day, our patients got it back in the 90s and even earlier.
Yeah.
Like I didn't know they weren't lifetime devices. So I don't think surgeons really educated their patients like we do now.
Yeah.
And so, I tell everyone, no implant's a lifetime device. Every implant's going to fail eventually and have a rupture. So what do you tell them about lifespan and monitoring? How do you educate your patients?
I tell them historically it's a rupture rate of around 1% per year. So you think 20 years, 20% chance you have a rupture. But I tell them that that's based on older implants, and the implants made now are made better than they were 20 years ago. And implants are one of the most studied devices on the medical market. So they're very safe. Rupture rate's very low. But for that reason, the FDA recommends screening them starting at 5 years with an ultrasound or MRI. And there's great options for that too. We're looking at purchasing an office ultrasound to screen our own patients. So that would start 5 years. Or we can send them for an MRI. I tell them that's not an MRI the insurance would cover. So we have a few places in town we can send patients, and they're usually fine with that. I think of it as part of their health maintenance. And I think, like I said, the chance of rupture is still really low, even when you do start checking them.
What about the question, should my implants be replaced every 10 years?
Yeah. I like that question because it kind of depends when they were placed. And I recommend what, the FDA, which is screen them. But I know there's a really, really good argument for if they're older implants, think about replacing them if they're some of the less cohesive gel, because it gets to be more involved, right? When you have to go in and replace an implant that ruptured, you're talking about removing the capsule and things. It's more surgery, it's more anesthesia, it's more cost, it's more downtime. So I tell patients, I kind of leave it up to them with some good education. If they've got a 15 or 20-year-old implants that are not ruptured yet, but they're thinking about it, how do you approach that with them?
Well, I tell them that with older technology, I would 100% agree with that because these shells were thinner and the gels were less cohesive. You could actually have gel bleed through an intact implant, and I think that could cause a capsular contracture. So I would say, yes, older implants, definitely every 10 years. But with this technology, I'm with you. I'm going to follow the guidelines and say imaging. If you do not have a rupture, you do not have a capsular contracture, and you don't want to change your size, then just watch them. But to me, those are 3 reasons for reoperation.
So let's say the flip side of that, with the newest implants with the highest cohesive gel, it's a tear in the shell, but really that gel's not going anywhere.
Right.
So what would you tell the patient that was happy, had no capsular contracture, but 5 years from now found a small tear in the implant?
I would replace it.
You would replace it?
Yes.
Okay.
Because
there's an argument that could be made that it's not going anywhere.
Right.
It's probably safe to leave it.
Well, it's not an emergency.
Right.
That's for sure.
Yeah.
But to me, I would not want that gel exposed. And
because we don't know.
Yeah, we don't
know.
know.
Yeah.
We don't know.
Yeah.
Even
I
if
would
it's very
agree with
cohesive
that.
in a monoblock, having the gel exposure could cause an inflammatory response that the shell's not going to cause, which could lead to a capsular contracture. And I'm trying to avoid that, just like you are. We're trying to avoid that.
100%. Yeah, I would agree. But if they've got something going on with their life, there's no urgency, if they want to get through summer or they've got a wedding coming up.
Yeah.
So how about women that have different size native breasts, one's bigger than the other, or they already have implants and they don't know what they have. How do you sort of sort that out when you're looking at either replacing or placing new implants?
Okay, good question. Well, I would say probably 10% of my patients get 2 different sizes because we see asymmetry very commonly. And sometimes it's not enough to warrant that. Like, look, you're used to this asymmetry. If I put a bigger size on your smaller, that may make your smaller breast now bigger. And you might be kind of weird because you've always had it the other way around.
Yeah.
So, but probably 10% of the time I'm putting 2 different sizes.
Okay.
And with the app that we have, it's very helpful to visualize that.
100%.
You go, is it worth the 2
Yeah.
different sizes, or you would just, accept your asymmetry and put it in the same size?
Yeah.
As far as redo breast surgery, I would say about half the time the patients have their information, which is phenomenal. I always congratulate them and say, good job. Made my life so much easier.
Right.
The other half the time I'm guessing, unless if they're old saline, we can deflate them in the office and get the volume, which is helpful. Otherwise, I'm bringing several options through an educated guess.
Yeah.
And I've done it so many times. I'm pretty accurate, but I do get fooled occasionally.
Sure.
I'm like, oh, I wish I had one more size. I didn't have, but
I've been there.
But that's how I...
Yeah. And then there's such thing as a sizer too, which a lot of patients don't know about.
Right.
Yeah.
Right.
So we can order those, bring that to the OR, and these are kind of like, they're implants that are not, they don't stay in a patient.
Yeah.
And you can use a saline one, you can get different volumes. And so there's ways in the OR to sort of figure out where they are, what fits them the best.
Right.
But should we talk about your Preservé training a little bit?
I do want to talk about that, but I thought just to be complete,
Sure,
we should discuss risks of having a breast augmentation surgery. Because, we both know this is a great procedure. Women love this procedure.
Yeah.
But no surgery goes without risks.
Yes.
So I always discuss the risks, which include anesthetic risks, bleeding, infection, hematoma requiring additional surgery. We've talked about capsular contracture quite a bit. Change in nipple sensation, which can be permanent. Statistically, a 3 to 5% risk of a permanent change in sensation. And then the remote risk of breast implant illness, which is a controversial topic. But in my experience, I do think it's real. I've probably seen 10 patients in my 23 years that have had it. And we take out the implants, they feel better.
Yes.
And I tell patients, this is years down the road. This doesn't happen right away. It's probably 6 to 10 years later you will experience this. So you just have that back of your head.
Yes.
That is a very remote risk of that, but
Thank you.
could happen.
Yeah.
So that's what I discuss with my patients, just to have them fully informed. And I know you do the same.
Yes.
But I just thought it should be covered before we move on to,
yes. Thank you. Thank
things.
you. And the newest, to sort of dovetail on your breast implant illness comment, there's some very recent data that's come out that's showing that you don't have to remove the capsules, which is used to be.
Yes.
So
that's a great
patients get better if you just remove the implants alone,
Yes.
Which is a lot less intense surgery. So if that becomes a talking point during a consultation, I always make sure to highlight that, because we can remove implants in the office if they are healthy and they're okay with that and they don't have any capsular disease and no rupture, like you said. Anyway, worth pointing out.
Yeah, I'll tell patients that for years, but sometimes they're so scared they want to have the additional surgery. And when I talk about the additional risk with that, but anyway. And I end up doing what they want, but I try to reassure them, look, just get the implant out. You're going to feel better.
Yeah. I agree. Okay, so then one of the newest things disrupting the breast implant market put out by Motiva is Preservé.
Yes.
Do you want to talk a little bit about that procedure and how it's different from traditional breast augmentation techniques?
I'd love to. So Preservé is a minimally invasive procedure where we're going to dissect the pocket with a balloon as opposed to using cautery. This is for smaller implants. The implant will be placed in front of the muscle, so there's no disruption of the muscle, so no animation, low risk of lateralization. And the idea behind this is that you want to preserve a structure called the circummammary ligament. This ligament establishes the footprint of the breast. And so we're going to preserve that to hold the implant and the breast in place. Should have very low risk of any bottoming out. We're using smaller implants. We're typically placing it higher and more medially because the goal of Preservé is to provide more upper breast fullness and more cleavage, not to make a really large implant. So you want to have volumes less than 300 cc's. And you want to use the ergonomic implant to help place the implant through the channel you're going to create. So I have a few little things here to help us. So we use the ring to design our pocket.
Okay.
And so we're going to place that, typically, like I said, higher, more medial than you would for typical augmentation.
Okay. So you're using that to draw on the patient?
On the patient prior to surgery. Like, okay, here's where we're going to put our implant. So we can customize that based on patient's shape and desires. But typically, like I said, it's higher, more medial. We're going to draw that. And then under general anesthesia or sedation, we will anesthetize the breast. And we're going to plane behind the breast tissue, but in front of the muscle. So there's a little fatty layer that everybody has. And that allows the breast to move over the muscle. It's not attached to the muscle. Once we anesthetize that, then we have our channel dissector. We'll make a small incision in the crease, and then we're going to create a channel for our balloon. That's removed. And then we have our balloon, which follows the channel. We get it, within our ring.
Yeah.
Then we pump up our balloon to make our dissection. So there's no cutting. So there should be little risk to any change in nipple sensation.
Yeah.
We're going to preserve that lateral breast tissue, and we're going to preserve that circummammary ligament. We're going to deflate this balloon, remove it, then use a funnel to insert our implant. And that's how a Preservé is performed.
Pretty straightforward.
Yeah.
Okay.
Yeah.
And so this is a different sort of sizing concept and sort of mindset.
Yes.
Compared to what we usually do.
Traditionally, we're taking breast measurements like we talked about earlier.
Yeah.
And I always say, look, I want the implant smaller than your natural breast width. So you get a natural result. You don't get a lot of lateral breast projection. So it's in your way when you're moving your arms.
Sure.
But this is really about upper breast fullness and cleavage.
Okay.
That's all we're trying to accomplish. You do get extra projection, obviously, but we're using smaller implants, but you get a lot for the amount of volume you think you're going to get. I mean, it's kind of crazy how, 200 is nothing, but 200 in a petite patient is a lot. And so you get a lot of projection, a lot of fullness, but you're not sizing the implant based on their breast width.
Oh, okay. Okay. How are you sizing it then?
Really, I'm relying on the app.
Okay.
And just talking through how we want to preserve their lateral breast tissue.
Okay.
So I want it narrower than their breast.
The app being our 3D sizing software?
Yeah.
Okay. And then, so there's sort of there's a few sort of boxes the patient has to check as far as who's the right candidate for this.
Yes.
Can you describe the sort of right patient or the patient group of patients that are good for this?
It's a primary augmentation patient.
Okay.
So they've already had the implant. They're going to have a pocket.
Right.
I just say you couldn't change planes, but that's not really what this is designed for.
So patients currently with implants are not candidates.
Right.
Okay.
And then, you can do either an augmentation only, or you can do a mastopexy in combination with this, so that they're not.
Which is with lift, yeah.
Yeah, a lift. So those patients are candidates as long as they don't already have an implant.
Okay.
And it's just someone who doesn't want just to dramatically increase their breasts. Because again, less than 300 cc's.
Okay.
So it really depends on the size of the patient.
Okay.
So I think of this as more, I won't say petite, but just if you have a really wide breast, this is probably not a good procedure for you, because it's not going to be, the implant's going to be wide enough to really enhance the shape of the breast correctly.
Okay.
So.
Okay. That makes sense.
But I think most women are candidates for it, who've not had an implant before.
Yeah. What are some of the selling points for Preservé? If patients could choose either, what would make them go with Preservé?
Well, it's minimally invasive.
Okay.
You're back to work the next day. You may not need any pain medication. There is
back to work, like even if they work on their feet, like okay,
you will probably not require any pain medication. There should be no decrease in sensation of the nipple roller complex, and there's no disruption to the muscle fibers because you're always going to place this in front of the muscle.
Sure.
So there's no risk of animation.
Okay. So they go back to normal activity the next day.
Not working out.
Okay.
I mean, if they had some kind of really physical job, that would not
Okay.
be ideal. But for most people,
typical weightlifting restriction then?
2 weeks
2 weeks.
to let the incision heal.
Yeah. Nothing more than what, 10 pounds per arm or so? Okay.
But full activity in 2 weeks.
Okay. Okay. Got it. So a lot faster recovery.
Yeah.
And it can be done in the office, right?
Not yet.
Not yet. Okay.
We may get there.
Okay.
But again, we've just started this procedure.
Yeah.
We're going to start with our patients very comfortable in the operating room first.
Sounds good.
And once we are comfortable with that, then we may proceed to the office.
Okay. Got it. I love that.
The only thing I would talk about, there's something very exciting. Motiva is really innovating the breast implant market. And so they have other implants available to Europe and Asia that aren't available to us that are even more soft. They have some implants that are identical front to back. So if it flips, there's no problem because it's the same front to back. They also have a technique called MIA where they're using a transaxillary approach and they're using the channel dissector to make a channel, balloon dissection, and then they have this little device that uses air compression to place the implant in the pocket in front of the muscle.
Wow.
So it just shoots air behind the implant to place the implant through the transaxillary approach. That is available in Europe and Costa Rica, but not in the US.
That's interesting.
Yeah.
And you mentioned with the Preservé, it has to be the ergonomics, which is the softer gel.
Yeah.
So if patients want the higher cohesivity, not a good Preservé candidate.
Because you need that elasticity of the implant shell and the gel to get it through that channel you've made to reach the implant pocket you dissected with the balloon.
And so patients that want a little more upper pole fullness are probably going to go towards the higher cohesivity, and they're not a Preservé candidate.
I mean, it really depends. Again, like, you know, it's so individualized. I think they should look at the crystallix and then make a decision.
Yeah.
And then we can offer either procedure.
Right. Okay. Yeah. Okay. That sounds good. Are there any other comments you want to make about the Preservé procedure?
No, I think it's exciting to have that innovation. I think, you know, for me, my evolution being in front of the muscles already really decreased downtime. But I think Preservé is going to give us maximum support of our implant with a very low complication risk of changing nipple sensation or any kind of bottoming out. So I'm excited about that.
Yeah. And I think once we are able to do it with just oral analgesia and oral anesthesia, not general, I think that's another reason that some patients, you know, they're hesitant about general anesthesia. Absolutely. So that's another thing that barrier that could be overcome, which is really exciting.
Yeah.
Wonderful. I have no other questions about Preservé. I'm excited to learn, excited to train.
Yeah. Well, I think that'll do it for this episode of The Aesthetic Angle. We hope we've answered all your questions about breast augmentation surgery and breast implants. If not, we're welcome to answer all of your questions in the office with a personalized consultation. Have a great day, everybody.